the span of 2 or 3 minutes, I would definitely be doing a great injustice. But I've already apologized to Dr. Ghousia that her introduction is going to be very short and sweet. So, Madam has graduated from her post-graduation from Ambedkar Indian College. She has held multiple academic positions in various colleges as a reader, as an assistant professor from 2010 to 2017. Presently, she heads the operational unit, and she's a senior consultant in Hosmat Hospital, that is Dental Healthcare and Research Unit at Garonda. She's been a consultant at various clinics and specialty centers. She is an editorial board member for American Journal of Medical and Dental Sciences, International Journal of Medicine and Medical Sciences, Journal of Dentistry, Medicine and Medical Sciences. She's a peer reviewer for many journals, and she has international publications, multiple publications. Just to name few, I think one of the rare case report, what she has given as juvenile fibromatosis of TMJ, and the other thing was pediatric oral pulse granuloma, which is a rare entity. She's got multiple national and international publications. The list goes and goes and goes and goes, and I think I need a separate webinar for that. The interest what has caught me in a CV is she's a hardcore foodie, and I love that. And joining her is Dr. Nyer Firdoose, and this gentleman definitely doesn't need much of introduction. He is an ocean of knowledge in himself, and imparting knowledge every day to every human being, to every person he's walking by. And he is a great influencer to me and to all the people around. He is an OMFS surgeon from Yanopoya University. He has a specialty training in cleft lip and palate from Smile Train, New York. He has a fellowship in implantology from USA, contributed to more than 10 national books, and he is an author of international book on dental implants and osseointegration. He has got multiple national and international publications. Presently, he is working as an associate consultant in MOH Riyadh, maxillofacial surgeon, MOH Riyadh. He is an inventor, a discoverer of unique anatomic variant that is coronoid foramina. He's an ardent researcher. These people are, the knowledge is an ocean in them, which I think it's just going to flow and flow and flow and flow, and we need to, take them drop by drop. Without wasting much of the time, I'm going to be your host and moderator for today. Without wasting much time, Dr. Ghousia is going to be on track on this special day, November 14th, being an Children's Day. Back to you, Dr. Ghousia. The dais is all yours. Thank you very much.
Sir, I think Dr. Ghousia lost the connection.
Oh. Dr. Ghousia? Yeah, I think we just lost her.
I'll just try to get back.
Yeah, can you just call her if you don't mind? Yeah, that would be great.
I think we are having a slight technical issue. I think Dr. Ghousia has lost the internet connection. We're just trying to get her back online. Inshallah, just a couple of minutes. We are really sorry and then apologies for the inconvenience.
Inshallah. Thank you, Dr. Firdoose. Yeah, great.
Shall we start?
Yeah, please do so. Can we have your video on also?
So video I'll keep off because there's technical, I think network is not working.
Right. The dais is all yours, Dr. Ghousia. Yeah, best of luck.
I'll request Dr. Nyer to start.
Hello and welcome to all those attending from different parts of the globe. My name is Dr. Nyer Firdoose and I'm a maxillofacial surgeon. This presentation is going to be a little different from the regular ones, as Dr. Ghousia will present it along with me as a joint presenter. We will try and make it as interesting as possible and not put you to sleep. So without much ado, let's start this. Over to you, Dr. Ghousia.
Hello, everybody. This is Dr. Ghousia, pediatric dentist, and I thank and acknowledge Dr. Nyer Firdoose for taking his valuable time amidst the working day to share some knowledge on the surgical aspects of infant teething. I also acknowledge our panel expert, the senior dentist, Dr. Nadeem Ahmed, for being part of this event, and I find myself privileged to be sharing the event with Dr. Nyer as well as Dr. Nadeem. So I thank you all and all the audience. I apologize for the technical glitch which happened. So without delaying, I would introduce you all to the topic for the day, that is the simply teething. So this topic is something which all of you are very familiar. So we're just revisiting this topic. This topic is something which most of the academia curriculum also misses out on speaking much. This is having no value for the exam point of view. For the students who are attending, should have no value because this usually is overlooked most often. But I would like to make a point that this is one of the most commonest scenario we come across in every day-to-day practice. So this is something which made me, and also spending time almost about 4 to 5 years in GDP house with n number of doubts from my own colleague fraternities of the other branches. I thought this topic needs a revisit from our side, and also to emphasize that as we unlock the mysteries of this important developmental milestone, also we are emphasizing on the fact that this simple procedure or a simple milestone as well needs a multidisciplinary approach. So it looks very simple, it's a very simple topic, but sometimes it does need a multidisciplinary approach, and that's when I had to rope in Dr. Nyer, the surgical team, for enabling us to carry on this presentation. So moving on to some of the medical folk wisdom. Now coming, why are we talking about this medical folk wisdom? If Dr. Mubarak is listening to me, he would definitely not want this slide to be here, but it is very important as much as how much of evidence is required. So for any science to be understood, we also need to understand the mindset of the layman. We also need to know how much, all of us like our grandparents, our daddies and nannies, irrespective of how much we like and how much alluring the stories are from our grandparents. We as clinical professionals, at least the ones who are dealing with science, definitely want to look forward and search evidence. So if Dr. Mubarak is listening, he would definitely, kind of ask me, why are we talking about medical folk wisdom? Now, medical folk wisdom is something without which we can't move forward and prove our points, especially to the patients who are the layman brains. Now, they come with their own set of treasured memories from their ancestrals, and also most of the topics are culturally sensitive. So when we are dealing with children especially, we need to maintain the ethnobiology as well as ethno-medical research value when we are talking or dealing with their cultural systems or rituals. So for the fact of that, we need to be aware, well equipped about all the systems or all the folk wisdom which has been spread across, and more so with our dental fraternity. Now, one such very popular folklore wisdom is going back to our ancestral or historic professionalism, even our professionals, the medicals and the dentists as well, were believing these medical folk wisdom, and which have led to a lot of confusion, which is even till date we are answerable to our patients when they come with their silly doubts. So one such is that the tooth buds or the tooth follicles were mistaken as the tooth germs most often, and they were the cause of most of the systemic illnesses the child was facing. And another point I would want to make, that most of these folk wisdom is very strangely and very fascinatingly associated only with the primary dentition or the infants. You don't see any of these associations or any of the stories or the folk wisdom associated with the permanent dentition. Now, this is something which intrigued me and asked me to explore further so that I can be in a well-equipped stance to make my patients understand and stand ground and make them understand the science behind what is right and what is wrong. It is very important. So when the patients, back then in centuries ago, when the people thought, or even the fraternity of our own medical and dental fraternity thought that there were tooth germs within the infant's mouth, which used to cause the systemic diseases like diarrhea, cholera, and so many other sleep regressions, which we will be covering in the subsequent slides. So, this led to a lot of confusion. And one such confusion is from our very own historic professional, Hippocrates, who was very fascinated by the number 7 and who thought, the infant's mortality rate was most commonly associated with teething issue. So irrespective of the comorbid condition the infant was going through, be it cholera, be it diarrhea, be it any viral infection, the easy diagnosis or all the blame game was put easily onto the teething issue. So one such very common one was the convulsions or the falling evil, which they used to name that way. And they used to consider that 12% of the deaths in infants used to happen were attributed mostly to the teething. You can see some of the clippings from the book from the very own Hippocrates publications, and this remained unchallenged. Now, he declared teething as the causative factor for most of the infant deaths mortality, irrespective of the comorbid. Now, this remained unchallenged. Now, this was declared in 4th BC and remained unchanneled and echoed almost till 19th century. So unfortunately, then John Clark, who is a neuropsychiatrist, also paved way, and he also was very naive to the electrical and neurochemical reactions of the brain, and thought that epilepsy or the children's infantile convulsions were basically attributed to teething only for the fact that the teeth germs or the tooth buds were basically innervated by trigeminal nerve, which were on the eruption of the tooth were causing a reflex reaction or stimulation leading to the other systems of the nervous system. So the nervous system of the infant was exclusively considered as very sensitive. So when the tooth germ was trying to erupt from the mucosa, this is a myth which I'm explaining y'all, and this understanding, if I'm not wrong, goes very strong even till date when we encounter patients asking, because of the tooth extraction, if your brain is affected or eyesight is lost. Now the whole of this is rooted back very back to almost the 4th century, and in 19th century, again, John Clark, which is a neuropsychiatrist, emphasized the fact that trigeminal neuralgia is innervated by these two germs. It gets reflex reactions and stimulates the other systems, leading to the disturbance in the systemic system and causing death of the infants. Now, thereby, another dentist, Dr. Thrasher, this is as early as like 1894, published a very important and very, popular journal in Dental Cosmos. And he also attributed teething factors and also gave a solution of the coral. The red coral was amazingly very popular amongst the rich people who can afford it, and they used to escape teething, unlike the poor fraternity or the poor population of the society back then. So always the rich used to escape the teething episode only because they asserted to these valuable, wealthy kind of ornaments or the god which is encrypted in these corals. They used to search from the deep down the seas and ask the child to make the infant wear below the neck. And sometimes they also wear these milk teeth as the good luck charm for the wards. And another gory practice which was back then practiced was applying electrocautery to the mastoid area just so that the tooth germs get deactivated. Now, so because of all this, there were gory practices. I would request Dr. Nyer to take over from here.
Not only is the road to triumph paved with blunders, but the bigger the prize, the bigger the potential blunder. Oral health can be defined as being multidimensional in nature, which includes physical, psychological, emotional, and social domains that are an integral to overall health and well-being. Now, we all know that lancets have been used since ancient times for bloodletting, opening abscesses, circumcision, and other minor operations. This slide in particular, we show you the different types of historical gum lancets used to mutilate the teething gums. The French surgeon Ambroise Paré from 1500s introduced lancing babies' gums, as it was considered a common norm due to the rampant belief of teething as a cause of severe illness or death in some. As already elaborated by Dr. Ghousia and the slight teething deaths, And opinions were increasingly divided and ambivalent, as often happens when a long tradition is losing popularity. And in the late 19th century, teething was beginning to be considered as a perfectly natural process. And thus came the so-called correcting blunders of nature. Traditional methods of treating illnesses are still practiced in several parts of the world and widely in Africa. Such traditional methods may not be scientifically explainable, and yet societies continue to apply them as a means to prevent and treat diseases. The term Ebinyo or Ebino is derived from Bantu-speaking ethnic groups of Uganda, which implies the traditional method of extracting unerupted teeth using crude objects like the impendo, as you can see in the bottom left of the slide. And this practice is an actual infant oral mutilation. The varied terms used to describe the practice of infant oral mutilation reflect the numerous geographical and tribal variations. Ibinyo or Ibino translates as false teeth, and the variations include killer teeth based on the belief that the child will die if they are not removed. In continuation of the infant oral mutilation, dental disruptions can be a result of the use of improper instruments to undertake the mutilation procedure. The less common forms include perforating the lower lips to enhance the beauty, and one such documented case is being shown here in this slide, which involved the perforation of the lower lip. And sometimes there's also lancing over the primary canine region as early as 5 months, or even lancing the uvula partly or completely in order to cure a respiratory illness or to prevent vomiting. Further complications of such rituals may be impaction and dislocation of permanent canines. Although late complications in ritual extractions are rare and mainly relate to chronic infections and mesial drifting of virtually all teeth in order to compensate and close the gap that results from extraction. Cases of speech disorders, mostly lisping, are common. And in the next slide, we will play a short video of the infant oral mutilation procedure being carried out in some parts of Africa. And over to you, Dr. Ghousia.
Just to make a point add on here before playing the video, I would like to say the root of removal of canines was also attributed to Hippocrates' fascination, because he was somewhere enthralled by the number 7. So the number 7, 7th month, the teeth comes, and even 7 years, the teeth primary dentition stays. So, and he referred to the most dangerous teeth along with John Clark, the eye teeth, which is actually the canine teeth. And that's why you saw in the previous slides that the canines were extirpated in particular. Now I'll be playing the slide, which is actually based on, it was actually played in group as well. So Mr. Raman Bedi, Dr. Raman Bedi is Professor Emeritus of College of London. He is somebody who's taken an initiative, the onus of stopping the infant oral mutilation in coming of 10 years. So a lot of campaigns and a lot of local language posters have been spread across. So this is a small video, and this video could be disturbing to the viewers. So discretion of the viewers is expected.
I'm Professor Raman Bedi, the chairman of the Global Child Dental Fund. What I'm about to show you is distressing, it's dangerous, and it shouldn't happen in today's society. This 1-year-old girl in Kenya has been taken by her parents to a traditional healer. Their belief is that her fever is caused by her canine teeth, which are still below the gum line. The swelling in the gums before the teeth erupt are believed to be tooth worms, and traditionally they are removed. The traditional healer is now using unsterilized instruments such as a bicycle spoke, a sharp instrument, or even a screwdriver to dig these teeth out. As you can imagine, this is harrowing and very painful experience for the child and very distressing to the parents. This is by no means an isolated case.
So this procedure was carried out without anesthesia, as we all noticed it. And also this could lead to unsterilized conditions. Because of the unsterilized instruments, this could lead to conditions such as osteomyelitis, noma, and even septicemia, hepatitis, HIV, hepatitis A, B in particular. So that is when, American Academy of Developmental Medicine and Dentistry published a paper and thought this should be, stopped. And this paved way to a declaration, Addis Ababa, so which is a capital of Ethiopia. And this particular documentation or declaration was come into form only by 2019, though the gentleman, Dr. Raman Bedi, has been working on it from 2014 on through via mails. We have all the pediatric dentists, I'm not sure how many pediatric dentists are listening, but most of the pediatric dentists in the group must have received his mail on urge for eradication of infant oral mutilation. I'm not sure if in our country it is practiced, but definitely in Somalia, Sudan, Ethiopia. So all these presidents, as you can see the signatures, they have been signing and they have taken a pledge. This is a charitable trust, a pledge for in coming 10 years, they want to eradicate this. And this is one of the crudest and the most, gruesome method of child abuse as considered in the dental fraternity till date. And it has to be stopped. So I would like to quote here, which suffices actually Raman Bedi: those who help a child help humanity with an immediateness which no other help given to human creature in any other stage of human life can possibly be given. So I urge my fellow fraternities here to take this declaration, today being the Children's Day. So I want you all to take up a pledge and create awareness of any of such superstitious or medical myth, which is leading to the gruesome, complications to the children, because the children suffer subsequently, and we want them to see the sunshine of tomorrow with a happy face. So that was in underdeveloped countries like Ethiopia, Sudan, and Kenya, which we saw. But the blaming of teething is not stopped in the Western or the developed countries or in the developing countries like us. One such condition is the sleep regression. So most often than not, even including the medical fraternity or the dental fraternity, unfortunately blames the sleep regression in the child for the teething episodes. But we are just looking at the teeth. Unfortunately, we're not looking at the child's growth as well. The child is physically developing, psychologically developing. So there are a lot of other factors which are happening. If you recollect the Paget's theory of cognitive, this is actually correlating or coexisting or coincidence age of object permanence, wherein the child starts getting aware of the surroundings, as well as the child understands that something which is out of sight still exists. So if the child is actually closing the eyes, it finds it difficult that, because after knowing the truth that the parent exists, it's difficult for the child to go to sleep. They'll start understanding this is something intellectual skill which the child attains at this age, and it causes a lot of disturbance. And the child is more inquisitive, curious, and exploring and wanting to see, and that leads to separation anxiety or stranger anxiety. And the child is not comfortably sleeping. This leads to regression of sleep. So this age and the age or 6 months age in the infant is actually coinciding, basically because the child is psychologically also developing, gaining an intellectual skill as an add-on. So this is most often overlooked. And again, the teething is blamed for. Another important condition to be blamed is the sudden infant death syndrome, which is an unexpected death syndrome, which is otherwise called the script death or the cot death. So one publication in the New England Journal of Medicine, that is NEJM, which I follow regularly. So this is an article which was published wherein they showed the diagrammatic representation of making the child sleep, not in a prone position could lead to asphyxia, because the child might inhale the rebreathing of the carbon dioxide. Another condition is the child can choke if the child is not changed with the sleeping position. It's very important to keep changing the position of the sleeping child. And as you see in the diagrammatic representation here, when the child is at the back, lying flat at the back, the trachea is superficial, and so if the child regurgitates, spits, it doesn't aspirate, because the trachea is above the esophagus, and the regurgitation can pass from the esophagus into the stomach, unlike the other picture wherein the esophagus is above the trachea. So any fluid ingestion or the aspirations can directly go into the trachea, choking death. So coming to the ABCs of sleep, safe sleep, if I have to tell for infants, it is about making the child sleep alone, of course at the invigilance of the parent, and at the back of the child, wherein the child's trachea is above the esophagus in case of regurgitation or anything, and of course in the crib. So this is the ABC. So again, these were the facts which we have dealt, as opposed to the myths which were blamed on teething. So another thing is about the teething virus. Now this is very interesting, which I thought was which occurred. This incident particularly occurred in the year 1982, wherein the psychiatrist as well as the pathologist were doing a particular study based on the hares the brain of the hare as well as the hair cells of the mice, and accidentally in the microscope they happen to find the saliva of the teething infant, and then they discovered, accidental discovery led to a virus which they attributed to the teething virus, leading to the death. So this was some kind of an accidental discovery which was deviated, and because of which the child was subjected, unfortunately, to the alcohol bath or the the ice bath, as you see in this picture. But again, that was overruled, and the reason for such fevers were coinciding again with the herpetic gingival stomatitis, because the child is moving around, crawling, walking, and hand-mouth coordination happens. The child is putting on stuff into the mouth, and inevitably saliva carriers herpes simplex virus. The portal of erupting gingival crevice, the teeth, gingival crevice of the erupting teeth actually becomes a portal for the HSV virus, the herpetic simplex virus, leading to the herpetic gingival stomatitis. But unfortunately, again, this becomes the cause for another historic waste basket diagnosis, or the trash can diagnosis, which does not have any medical evidence. So there is no such thing as teething virus, because there are a lot of articles on teething virus, but otherwise this is herpetic gingival stomatitis. Another very recent, or it's still going rounds, making rounds in the social platform, which I see, is the vaccination and teething. There's a myth, very non-evidence based misinformation based on the vaccination related to teething. There's some norm wherein the parents are stopped from vaccinating their kids when there are teeth days as opposed to the non-teeth days. But unfortunately, the child is undergoing this, the teething symptom for 20 times. There are 20 primary teeth which are occurring in a period of 6 months to 2 years. And that is the time when your vaccination are scheduled. Now, mild fever, cough, cold, running nose should not be ruling out the cause of not rescheduling or cancelling the vaccination. Of course, the pediatrician in question will be the upper hand. So always consult a pediatrician. If the symptoms are mild and the vaccination can go on, please continue the vaccination for the child. And don't, in fact, even the dentists are being asked, especially with the ongoing pandemic, if the vaccinations have to be given to the teething child. So, I request the fraternity friends to be well equipped with the information that vaccinations and teething are not in concern. There's a very unpopular belief that, erupting teeth causes noxious stimuli directly to the brain. The vaccination toxins reaches to the brain and causes the nervous disturbance, because again, the root is trigeminal nerve being connected to the tooth and so on. So in the year 2010, the Center Disease Control, as well as the American Academy of Pediatric Dentistry, along with JAPA, have released a statement which goes unnoticed most often. And in fact, they stress upon the fact that vaccination has to be given, otherwise the child may land up with the serious illnesses and may lose life. So vaccinations cannot be rescheduled or cancelled because of the teething episode based on the teeth or non-teeth days. So after moving on from all the myths or the folk wisdoms, finally coming on to some science, that is the teething truth. Now, what is teething truth? Technically, it is otherwise known as odontiasis. And of course, so we have a lot of people, actually we see more often than not put up in the group as well. The eruption bulge is often, asked as query as what this is. So there is a lack of awareness amongst parents as well as the fraternity friends that eruption bulge is a normal occurrence. The gingival inflammation, eruption gingivitis, inflammation is basically very common episode of pre-teething. That is basically because dental follicle is rich in interleukins, iconocytes, and prostaglandins. So therefore, the inflammatory process is very high around the tooth just before, and the tooth eruption particularly takes in 8 days, and 5th day the tooth appears. So there's a lot of irritation, gingival irritation. Mind you all, always the teething episodes is based only for the local symptoms. All the systemic symptoms have been ruled out if you all recollect the previous slides. So all the systemic symptoms are not attributed to the teething episodes. Teething is only local process, and only local symptoms can be witnessed. So one of the prominent symptom is the inflammation of gingiva. I already told you all, dental follicle is rich in the interleukins, prostaglandins, and that's when you see the inflammation or the eruption bulge. And definitely the statement, the winds started changing by 1970s when Ronald Ellingsworth stated, teething produces nothing but the teeth. So the focus is only on the local symptoms like inflammation, and subsequent signs will be discussed in the later slides. So teething particularly is basically the vertical eruption of the dental follicle in an axial direction. So there is a vertical pathway of teething eruption. Just that thought crossed my mind. I'll discuss in the next slide. So the stages of teething. This is basically in a parent education slide or the picture for us to remember. So basically, as we all know, the eruption timeline, 6 months to 8 months, and another short way of remembering them is 6 months minus 6 gives you the number of teeth in a child aged from 6 months to 2 years of age, but that's in a very arbitrary position. So you see the lower incisors first, most often than not, then the upper incisors come in, and upper incisors, the age of 6 to 10 months is when the child starts weaning. And there is a lot of dribbling because the child starts weaning, exploring, hand-mouth coordination happens. If you remember the cognitive Paget's theory, wherein the child is exploring through the mouth. Now the mouth is a very favorite toy for the child, and the teeth becomes the weapon or the toy. Likewise, for weapon, sometimes if the child is agitated, and of course, then you have the first molars erupting and canines erupt, deciduous canines erupt, and the second molars erupt. This is the normal sequence, or pretty common sequence, which is seen in the children. Like now, this is the emergence phase of eruption of primary dentition. So always remember the primary dentition. The point which I wanted to make here basically is the primary teeth always, as per Moyer's or Profit, they have vertical axial pathway of eruption, unlike our permanent teeth. Permanent teeth, you see there is a mesial, inclination, most often mesial, sometimes distal inclination, as you see in impaction molars or something. But that is the whole idea why we do not, in case of missing primary teeth, we do not suggest any space maintainer until there is an intervention of a permanent teeth, be it an incisor or a molar. So till then, if the primary teeth is lost because of trauma or because of any other reason, I don't think so a space maintainer has to be there, simply because the teeth of the deciduous dentition are always vertical or axial in eruption. So this is one of the slides which shows the pre-emergent development where there is no clinical signs, the gum pad stage, there is basically no clinical signs of eruption, but then you see the eruption bulge or the eruption teeth which is happening. So basically the tooth from the follicle is with the incomplete root development is trying to tear through the gingiva. Sometimes bleeding occurs in this stage. So that becomes a cause of concern for the parents as well as paranoia for the clinicians who are not aware of the condition. So bleeding is very common if the gingiva in this particular area is inflamed. Bleeding is very common, and the tooth tears down through the intraosseous by resorption of the alveolar bone. That is the intraosseous tooth development, and then you see the post-emergent wherein the cusp emergence happen. Another controversy dealing with this issue is there is the terminology issue, especially for the academicians, that emergence versus eruption. So the better term, most opposed or commonly, though it is not introduced in our textbooks as yet. So eruption is not the right term, but they oppose to, and they want us to suggest and utilize the term emergence, as the tooth emerge through the intraosseous and through the gingiva and reach the occlusal stability. So these are the three emergence phases of eruption of primary dentition, that is a pre-emergent, intraosseous, and post-emergent state. So moving on to the transitional phase or oscillating pattern of eruption. So what happens here, basically, there was a study, single study so far done by Holland because of the limitations of the child, subjects. It's not easy to do any study or follow-up studies or original studies on the children owing to their cognitive abilities or cooperations and the consent from the parents in particular. So what happens here is they have observed, Holland and the other authors have observed that many of the deciduous teeth appear to demonstrate an oscillating pattern. But again, this stands for debate because not exactly oscillating pattern, but the better terminology will be transitional phase, because unerupted, the incomplete root developed tooth which emerges, the deciduous tooth, because of the intrusive forces of the occlusion or because of the tongue, cheek, suckling, swallowing, all these pressures, the negative pressure which is happening into the oral cavity because of the suckling, sucking, swallowing, breathing. Sometimes the intrusive forces allow the tooth to dip in, and then it regrets or it retreats itself within an hour. Also, there is a debate that, it may not be actually intrusively going into the alveolar socket, but basically because the surrounding gingival inflammation or the bulging is so prominent that the teeth appears to be, oscillating or supposed to be retreating and appearing. So anyways, so we decided to term, or the authors themselves decided to term this as transitional phase of eruption. This again is a cause of concern because the parents, I don't know, even in a group, I think Dr. Bashir had posted a case wherein the tooth appeared for for particular days, and then the tooth, because of intrusive forces, had disappeared. The child had undergone trauma. So that is when we say the intrusion, when kind of trauma happens in the intrusion, we ask the child or the parents to leave it alone, because the intrusion can be self-correcting. That is because of the phenomenon of this oscillating pattern of the transitional phase, wherein within an hour or maximum, if the root is completely developed, within a week, the tooth has to appear into the oral cavity. Now, another such, changes which we see. Now, this finding or this learning is attributed completely to the GDP house dental couples, basically, because my inbox way back from past 5-6 years from when the GDP house is initiated has been flooding with a lot of questions, because we have a lot of new parents into the group and a lot of learned parents, and more particularly the dental parents. So they have, all the eyes and all the noticing happening into the oral cavity. So there are a lot of doubts which pop in, and I felt myself not very equipped as a pediatric dentist when their doubts were coming up, and that is when I had come across this learning. That is the polymorphism. That is a changing trend in eruption sequence pattern of primary teeth. So what happens here? Basically, this the causative factor could be environmental, though it is not very evidence-based, and still a lot of research has to be done. But then I did see 2 articles from Shobha Tandon and one from Dr. Nandalal, pediatric dentists, so where they have published the original researches as early as like 2018-19, and probably because of the pandemic, the researches have been stopped. So these are 2 pictures wherein depicting the polymorphism, wherein the change in pattern, which we saw the stages or the patterns, the regular pattern, all of us are very allude or very, kind of very accustomed to the regular pattern. But here, when we see a disturbance, when the lateral comes before or the maxillolateral comes before, then we are panicking and we start asking questions, especially if we are learned parents. So this is another case wherein you have reverse polymorphism, wherein the first polar erupting before the deciduous. Now, this condition is most commonly seen in the mandible, though it is the rarest of rare, but 33% of the literature, as per the literature, 33% of the cases have been shown, which attributes to the mandible alone, and some 9% of the cases have been seen in maxillary. So this is another finding which we as clinicians or dental practitioners should be equipped if the parents come and ask us the questions. Now, as we move on with the eruption, there are some developmental variations in infant teething, which is attributing to the morphology, basically. Now, when we, in the infant teething, when we see abnormal shapes, as in you see the picture here of depicting the ectodermal dysplasia, the conical peck-shaped teeth, so that again becomes a cause of concern for the parents when they see the contemporary couples having kids with regular shaped teeth. And this turns out, so this is an alarming sign for the clinician or the dentist to check back with the medical fraternity and rule out few of the medical systemic conditions. So basically, this dentition may not have all the teeth, hypodontia, that is a missing teeth, or alveolar itself can be hypoplastic, and there can be lip eversion. So we as dental fraternity should be very well equipped in finding out such things, because we might be the first people to be approached for such anomalies. The other concern could be the aesthetics, which the parent anxiety can be alleviated by shaping of the aesthetic teeth of these teeth. Then you have the triplication defect. This is one of the case. Of course, the literature also shows cases wherein you have fusion or you have triplication, gemination. This again can be a cause of concern for the parent wherein you see fusion of 2 teeth, and here in this case there is a supernumerary teeth and the lateral getting fused. So this can again be a cause of concern. Also, educating the parents about such consequences happening in the permanent dentition is also our duty. Another concern here can be of the oral hygiene maintenance. Because of the grooves and demarcation, hygiene can be a cause of concern, leading to a lot of pulp therapies or involvement of caries. Another such condition is the syphilitic teeth, wherein screwdriver incisors are seen, mulberry molars are seen. So these are the morphological variations. So we have moved from the folk wisdom, the myths, then we came on to the teething truths. We covered the eruption pattern, the stages of eruption. Then we moved on to the developmental variations, which actually exhibiting the morphology so far. And so moving on to the next criteria, that is the discolored infant teething. Now, this is again a cause of concern. I'm sure many of us are very much aware. It's been discussed multiple times in the group. So we have the chromogenic bacteria maximum in the children, because owing to the microflora being rich, immature, and tongue being the hub, and the oral hygiene practices are not very severe. So the black stains, which you see, is very common on the upper slide. Sorry, the upper picture of the slide. So this can be this picture depicts the exogenous or the extrinsic stains, which can be removed from the professional cleaning or the proper oral hygiene brushing. The second picture shows the orange typical stains. Now, orange stains are again common in children because of the chromogenic bacteria Serratia marcescens. This is a very favorite question in the academic curriculum. This is very common in children, especially towards the western part of the world. And another picture, the last picture, which shows is a typical case, very rare though, the fluorosis of primary dentition. The fluorosis of primary dentition escapes because of the placental barrier, but there are rare cases wherein, as seen in this published case, this is a published case found. So this shows typical fluorosis in the primary dentition as well. So apart from the upper black stains and the orange stain, the lower dental fluorosis is of course the intrinsic stain, which cannot be helped by the professional cleaning, but rather needs some aesthetic concerns if the parents are keen on it. So moving on to the other conditions of discoloration, as in seen in congenital erythroporphyria. So here you see two important cases, which are the excerpts of the published papers. So I thought these are like proper demarcated. Of course, these are the severe forms of the cases. We might be coming across some milder forms also, but I thought it is important to see the severest form as the teeth is erupting, the congenital erythroporphyria teeth. This is the condition. So this should alarm the dentist and should seek help from the medical fraternity, because most often than not, like I told you all, parents seek first attention to dentists because it's involving the teeth. So bilirubinemia, wherein you see the unconjugated bilirubin being settling into the dental tissues, rendering the teeth to be green. And then you see another picture, which is a milder form, which has a complete demarcation. These are all infant teeth, and this is because of the cholestatic neonatal jaundice or any respiratory distress syndrome also shows it. Some rare cases of tetracycline deposition or amoxicillin also show green color deposition into the teeth. So the systemic conditions needs to be ruled out with the medical fraternity. Other two conditions exhibiting the infant teething, which exhibits the dentinogenesis imperfecta as well as amylogenesis imperfecta. Of course, this is genetic and autosomal in origin. And the cause of concern can be attrition, because the child is otherwise going through a lot of occlusal delirium. There's a lot of occlusal instability. The child is not completely occlusally stabilized. So there's a lot of erosion, attrition in the primary teeth, otherwise in normal enamel dentin, owing even to the enamel thickness, less enamel thickness and dentin thickness, but with the additional condition of amylogenesis imperfecta and dentinogenesis, pulp therapies can be multiple, leading to multiple crowns as well. So coming on back again to the eruption. So we saw in eruption, the phases, the morphologic changes, the discoloration. Now what happens if the eruption of the teeth doesn't happen at all? If there's a delayed teeth? So that again becomes a cause of concern to the parents, because all their contemporaries of the children age group are having teeth, but then our child is not having teeth. Now also I would like to mention some myth, because there's a popular myth in Chinese population as well as in ancient countries, wherein the child cannot face the mirror unless the child is having the first tooth. So that becomes a cause of concern for most of the grandparents. The child is not able to play with the mirror, or because they want the child to face the mirror only with the tooth. Otherwise, it's considered as a bad luck. So also some consider it as a sign of intelligence, but of course that myth is busted. And there's no concern, there's no connection or evidence based with respect to the intellectual intelligence quotient as well as the late eruption of teething. So coming to the science now, any concern teeth can be waited. The eruption of the infant teething can be given time till 15 months of the age of the infant. But anything longer than 18 months demands a intervention from the professional team. So be it a pediatric dentist or the pediatrician, they have to intervene, take the investigatory procedures locally, but systemically, again, few conditions needs to be ruled out, like syndromes, hypothyroidism, hypopituitarism, and a lot of other conditions which I mentioned here, like asthma, hypertension. This basically is because of the gestational diabetes or gestational smoking of the mother's habits, or any of the drugs which were used, which influences the teething, delayed in teething. Now, another condition which can cause the worry is early eruption of teeth or precocious predecidual teeth, dentitia precox, or otherwise known as, technically it is otherwise called as expulsive captapont follicle. That is your natal and neonatal teeth. Now, the details will be dealt by Dr. Nyer here, but I just want to tell that the natal teeth are common, most common when compared to the neonatal teeth. Natal teeth are appearing immediately at birth. Neonatal comes within 1 month or 30 days of the child's birth. Also, this is very rare condition. 1 in 3,000 or 1 in 2,500 population see it. And you know, the reasons can be many, and also it can ruling out syndromic conditions or systemic conditions also becomes very important for the clinician if there is eventful birth history or natal history, prenatal history. So that's very important from the dental perspective. Moving on to the myths associated with the natal teeth. So the quote, as mentioned by Shakespeare on the natal teeth when referring to the Henry VI, which says that the people or the children born with natal teeth actually bite onto the world. That is the conquerors of the world. And also to mention few more you know, legends who were born with the natal teeth were Julius Caesar, Napoleon Bonaparte. So people or the children who were born with natal teeth are actually considered lucky, but the girls in particular, if they were born with natal teeth or sporting the natal teeth, then they're considered a bad omen, and the child biting the nipple of the mother can kill the mother, was what the belief was, and that's why this child was abandoned. Now, to mention here one such circumstance which I came across in the southern part of the city during my consultation times in one of the reputed corporate hospitals which I used to consult, wherein the pediatrician and the neonatologist had to consult with me. And you know, the case was such that there was a girl child in a very well-off, well-educated family, but this was a girl child with sporting a natal tooth. But the parents wanted to abandon this child, the only reason being the child was considered to be the bad omen. So I felt very sorry, and you know, that is when the education and the dispelling of the myths is very important. And I urge my fraternity yet again on this Children's Day, let us take the onus, let us become the strong activists in dispelling the myths related to repeating natal teething or infant oral mutilation, or be it anything, when you know when the child's safety is at stake. So the onus is on us, on me and you, and spreading the awareness. And that's the whole idea why I took up this simple teething topic, just to make aware, so that as much as awareness, because something like 2014, 2015, the parents of this era of suburban population from a city like ours wanted to abandon a girl child just because the child was born with a natal tooth, which was an unfortunate event. And then the medical fraternity, or you know, not much can be done from our side, because this is a very sensitive and a very cultural issue, and the grandparents definitely didn't want the child to welcome into their family. Now, coming on to the classification, just before passing on to Dr. Nyer. So this is the classification of the Hebling classification, 1997. This classifies the natal as well as neonatal teeth. This is available in most of the theory textbooks. So class 1, shell-shaped crown poorly fixed to the alveolus, gingival tissue and absence of root is there. Class 2, you have solid crown poorly fixed to the alveolus and no root at all. Class 3, there's eruption of incisal margin of the crown length through gingival tissue. Class 4, there's just edema of the gingival tissue. Now here it is very important to know that, you know, another classification which can be generally told as, like, you know, supernumerary as opposed to the regular primary dentition. Now, most of the natal teeth which appear can be a set of primary dentition. 90% of the teeth will be of primary dentition. Only the other percent can be of supernumerary. And so, you know, we can rule out with a radiograph as well. And also depending on the mobility or the stability, the integrity of PDL or the periodontal ligament, as well as the stability of the root will help us to judge whether the tooth belongs to the class of primary dentition or if it's a supernumerary tooth. So another, this is the clinical picture of a natal tooth, which has hypoplastic shell-like crown, underdeveloped roots. So enamel and dentin are irregular here. I could manage to get few articles on the histopathology of the natal and neonatal teeth, which shows high increased inflammatory cells. Now the inflammation is so high that in a regular tooth, if the infant had got this eruption, there would be toothache. Now why there is no toothache in these children? They seem to be asymptomatic basically because there's no internal pressure because of the poorly formed or atypical dentin dentin pattern. And also to be noted here is there is absence of cementum, absence of cemento-enamel junction in these teeth, but inflammation, as you see here, there is a high inflammatory cells which are seen. And another picture which depicts the mesodistal position or the histopathology report of the mesodistal picture as well as the labiolingual picture of the natal and neonatal teeth. And another point to be made here is these teeth in particular are very rich in stem cells. So this has to be made a point. So these are very important and very rich in stem cells, and they can be helped in regenerative, especially if the child is afflicted with neurodevelopmental disorders like autism or cerebral palsy. So these teeth, if encountered, if preserved, can help the child in future. Of course, that is again into a lot of research, but I just wanted to make a point that a lot of research is going on in the stem cells of the natal and neonatal teeth as well. Just before moving on, giving on the slides to Dr. Nyer, I'll be mentioning about the clinical condition related to the natal teeth often, which is actually a reactive mucosal lesion, popularly known as Riga-Fede disease. This is attributed to two finders. In 1881, Antonio Riga had documented this case, but was published by Fede and hence the name. So most appropriate or clinical term can be neonatal sublingual traumatic ulceration. Now here, the infant is refused to nurse. So this can lead to a failure to thrive of the child because the child is not feeding on. There's a constant movement of tongue and irritation happens. So as you see there, there's an ulceration with indurated margins and quite a painful scenario for the infant. Another thing to be mentioned here is that Riga-Fede disease recently have been classified by Dominic Cruz et al. As late Riga-Fede disease and early Riga-Fede disease. Exclusively, early Riga-Fede disease is exclusive to the natal and neonatal teeth, but Riga-Fede disease, which is late in occurrence, is attributed to the primary dentition, wherein wherein there is ulceration in the ventral side of the tongue. Now, another point before I move on to the next clinical condition is Riga-Fede disease is exclusive to the tongue and is an isolated condition most often. But if it comes with syndrome, it has to be ruled out. And that is when you need a surgical intervention for the surgical biopsy. Excisional biopsy needs general anesthesia because otherwise you're not doing justice to the biopsy tissue, and then your diagnosis can be underrated. So another condition along with Riga-Fede disease, just before moving on, is the duxae, that is the traumatic ulcerative granuloma with stromal eosinophilia. Here, this condition has increased eosinophils. Now, this condition may not be exclusively to the tongue. It can occur in the cheeks, lips, and then tongue. Also, this cannot be attributed only to the infants, but this is also seen in the late adulthood or preteen kids as well. So over to you, Dr. Nyer.
A quick add-on before we move to the next slide. The differential diagnosis includes infective and neoplastic conditions for Riga-Fede. Therefore, histological diagnosis is required when the symptoms fail to resolve with standard management. The published literature indicates that at least 1/4 of the documented cases of Riga-Fede are associated with underlying neurodevelopmental disorders such as encephalopathy, microcephaly, cerebral palsy, familial dysautonomia, and a few syndromes may also be associated with this condition, such as Lesch-Nyhan syndrome, Tourette syndrome, and also Down syndrome. Now, the treatment of Riga-Fede disease varies from excision of the lesion to smoothing of the sharp incisal edges or rounding of the sharp edges of the tooth with composite increments or stoma acid wafers or rings. In the next few slides, I will be dealing with the natal and neonatal teeth in continuation, and the presence of teeth at birth is termed as natal teeth, which in newborns is uncommon. The incidence varying from 1:2000 to 1:3500 cases, occurring in general with instances of 2 or 3 teeth. In few documented cases, as in the bottom right picture, there are multiple neonatal teeth. This is the photograph of a 20-day-old girl, which is brought to a surgical practice for the multiple bumps in the mandible, and then a couple of neonatal teeth, natal teeth, and the posterior maxilla. And the folklore and misconceptions surrounding natal and neonatal teeth vary and have already been dealt with by Dr. Ghousia. And the etiology of neonatal teeth and natal teeth is very debatable. And a few of the hypotheses include dominant autosomal gene as an hereditary transmission, and there are multiple endocrine disturbances, poor nutrition status during the maternal gestation period, and superficial positioning of the tooth germ, and environmental factors such as the polychlorinated biphenyls. The most acceptable of these is the superficial presence of tooth germ, and the decision to keep or to extract such teeth should be evaluated in each cases, keeping in mind the scientific knowledge, clinical common sense, and parental opinions. These teeth can be present either on the anterior region, as you can see in this slide in the top right picture, or they can also be present in the posterior region as shown in this slide. The main reason for seeking professional help in such cases is number one, potential risk of aspiration if the teeth are mobile. Number two being ulcerations in the ventral aspect of tongue, as in Riga fede and tuxe, as mentioned in the previous slides. And most importantly, the third one is the difficulty feeding or refusal to feed. And also the ulceration of nipple and interferences in breastfeeding. The treatment and management is removal and is indicated when they are poorly developed, interfere with feeding, and highly mobile, and associated with soft tissue growth. The child should be followed up for assessment of eruption and prognosis, and also presence or absence of remaining deciduous or permanent dentition. Interestingly, multiple natal teeth may be more likely to occur in children afflicted with certain syndromes or health issues affecting growth, which may include and not limited to Ellis-Van-Creveld syndrome, which is also known as condylectal terminal dysplasia, the Soto syndrome, Pachyonychia congenita, and Hallermann-Streiff syndrome. The picture on the right is from a child diagnosed with Langerhans cell histiocytosis. Natal and neonatal teeth have been a subject of curiosity and study since the time it was first discovered by Titus Livius in 59 BC. The multiple terminologies have already been discussed and dealt with by Dr. Ghousia, and due to the lack of specificity and accuracy in description of the condition, this led to the subsequent discontinuity of the use of such terms. The analogous terms of natal and neonatal teeth described by Maffler and Savara are now the most widely accepted. They termed all teeth that are present at birth as natal teeth, and those that erupt during the neonatal period, that is the first 30 days of life, as neonatal teeth. In the past, neonatal teeth were merely considered cysts of the dental lamina of the newborn, and normally they appear cuneiform, white in color, and composed of compact keratin, and projected above the alveolar ridges. Neonatal teeth, the diagnosis requires a detailed case history accompanied by thorough clinical and radiographic examination of the infant. And it is important to rule out any by radiographic examination whether there are components of normal dentition or supernumerary to decide the treatment plan. This slide is a consequence of management aspect of the natal and neonatal teeth, and we all know vitamin K is necessary for the synthesis of coagulation factors. The background of prophylactic vitamin K injections is full-term infants, especially those who are actually and exclusively breastfed, are deficient in vitamin K and consequently may have vitamin K deficiency bleeding. And preterm infants are potentially at greater risk for vitamin K deficiency bleeding because of the delayed feeding and subsequent delay in the colonization of their gastrointestinal system with vitamin K producing microflora, as well as immature hepatic and hemostatic function. Therefore, these days it's very common to advise and then give a prophylactic administration of vitamin K in the dosage of 0.5 to 1 milligram intramuscularly because of the risk of hemorrhage, as the commensal flora of the intestine might not have been established until the child is 10 days old. Also, the clinician should assess the risk of hemorrhage due to the hyperproteinemia commonly present in newborns. For those parents who refuse intramuscular injection at birth, per oral 2 milligrams at birth, followed by 2 to 4 weeks, and then again the subsequent dose of 6 to 8 weeks is recommended. The association of peripheral ossifying fibroma with natal and neonatal teeth is extremely rare. It is most likely to be originating from the cells of periodontal ligament according to the various hypotheses proposed in the literature, and trauma, local irritants such as calculus, plaque, ill-fitting restorations, and appliances have been attributed towards its etiology in the form of chronic irritants. In the current slide, we show you the intraoral clinical picture of two distinct pedunculated firm soft tissue growth attached to the alveolar crest of the mandibular anterior region. And on the top right, an intraoral periapical radiograph of the same mandibular anterior region showing soft tissue shadow along with irregular radiopacity within it, suggestive of calcification and underlying tooth buds of primary teeth. In this case, the source of trauma or irritation is presence of natal teeth. In spite of being a benign reactive lesion, a high recurrence rate has been reported. The reason for surgical intervention is impairment of infant feeding, thus affecting the physical and cognitive development of the child. And being a superficial lesion, the surgery involves only excision without disturbing the deciduous tooth buds, in most cases to aid normal eruption sequence. Such lesions require long-term follow-up subsequent to excision with histopathological examination due to the high recurrence rate. Let's look at some of the pre-teething aspects. Babies can experience teething differently, with some showing signs of distress. From grandmothers to medical professionals, everyone seems to have a list of symptoms they believe are linked to teething. During this time period of an infant's life, a passive immunity due to maternal antibodies wane and exposure to a wide variety of childhood illnesses occur. There are parental false beliefs associated with teething, which may interfere with the prompt diagnosis and management of a range of serious illnesses. Such strong parental beliefs, which are not borne out by evidence, will unlikely change until professionals, most of whom are also parents, change their opinions. Therefore, there is a need to know the facts and the false beliefs attributed to teething. In this slide, I want to show you a few such aspects like congenital epulis, which you can see on the either side of the slide, or a rare tumor of a newborn, and a case from our very own group member, Dr. Ramesh. We thank him for lending us this clinical picture and radiograph of an infant with mucosal calcified nodule. The reasons for such entities are still under extensive research, and sufficing non-invasive approach is not an option in such cases, and surgical intervention may be needed to help ease the feeding. I am sure Dr. Ghousia will disagree, as she is more inclined for a palliative approach. Do you want to add something, or shall I continue?
No, with the time constraints, I would request you to continue. But of course, the degree of the severity, as well as the, if it is a palliative, it's a small size, or the moderation, if it's not secondarily infected, then palliative approach can, I'm sure Dr. Nyer also will agree. And you can continue, Dr. Nyer.
Eruption cyst is a benign cyst associated with a primary or permanent tooth in its soft tissue phase after erupting through the bone. Eruption cyst is the soft tissue analog of the dentigerous cyst, but recognized as a separate clinical entity. Although there are a number of theories about their origin, both seem to arise from the separation of the epithelium from the enamel of the crown of the tooth due to the accumulation of fluid or blood in a dilated follicular space. The prevalence of eruption cyst is uncommon, and literature reveals low prevalence. The reason being that many classify them among the dentigerous cyst, and in addition, since they are benign, there are few studies in which a definitive diagnosis was done using biopsy. Most eruption cysts occur in the age group of 6 to 9 years, which coincide with the eruption of the permanent first molars and incisors. However, there is evidence of neonatal lesions also, and the etiology is again unclear, but early caries, trauma, infection, and the deficient space of eruption can be a possible causative factors. These cysts do not require treatment, and majority of the time they disappear on their own. Surgical intervention is required only when they hurt, bleed, or infected, or for aesthetic reasons. The eruption hematoma occurs because of bleeding from the gum tissue during eruption, and the accumulation of blood is external to the epithelium of the enamel. This is seen around the primary second molar or permanent first molar region, and a few studies reported that if bleeding occurs within the cyst due to trauma or local irritation or infection, the eruption cyst becomes bluish in color and is then known as an eruption hematoma. This can occur in different age groups, that is, it can correspond to the normal period of eruption of deciduous or permanent teeth from newborns associated with natal teeth to young patients. In relation to the treatment perspective, most cases do not require immediate intervention because the tooth erupts normally and the condition disappears spontaneously, and any intervention should be postponed. Therefore, surgical intervention is required only in cases of pain and discomfort, and if there is lack of spontaneous regression and compromising of dental eruption. In addition, the monitoring of the eruption of the teeth involved is very important. Abnormalities in the oral cavity of infants are not uncommon, but most are innocuous and resolve with age in the absence of treatment. Some of the most prevalent oral findings are oral inclusion cyst, ankylosing, vascular lesions, and natal teeth. The oral inclusion cysts are described as white raised multiple nodules of the maxillary and mandibular alveolar ridges and mid-palate regions. It was Dr. Alfred Fromm in 1967 who classified oral inclusion cysts depending on the location as either Epstein pearls, that is at the location as midline, raphe, or near the junction of the hard and soft palate. Then the second one being the Bond's nodules, which is the buccal and lingual areas of the dental ridges, and or dental lamina cysts, which are located over the alveolar ridges, which I will cover in the next coming slides. In this slide, the Epstein pearls are small, harmless cysts that form in a newborn's mouth during the early weeks and months of development. The bumps contain keratin, a protein that occurs naturally in human skin, hair, and nails, and these Epstein pearls go away on their own within a few weeks of the baby's birth and not a cause of concern. Bond's nodules are those found along the buccal and lingual aspects of the dental ridges, and most of the inclusion cysts of the alveolar crest and the mid-palate region are apparently due to the discharged keratin shortly after birth. Several reports have stated a transient nature of these cysts by discharge of keratin at the time of fusion of cystic walls with the oral epithelium. Currently, the palatal cysts of the newborn are the preferred term used instead of Epstein pearls, Bond's nodules, or gingival cyst of newborn. The cyst usually disappears spontaneously between 1 to 2 weeks of birth. All that is needed is a spell of reassurance to the worried parents by the well-informed professionals about the benignness and self-limiting nature of such lesions. The third entity, which is the dental lamina cyst of the oral inclusion cyst category. In this slide, you can see both the maxillary and the mandibular version. These cysts arise from the developing dental tissues or from their remnants. The cystic lesions are not commonly seen by the dental surgeons due to their self-limiting nature and ignorance of the parents to seek professional opinion. However, when contacted by anxious parents seeking treatment, dental surgeons should be able to explain and reassure the parents about the transient nature of these lesions and need for no further treatment but regular just follow-up. To sum the previous two and this slide up, I would like to mention the intraoral cystic lesions with characteristic clinical appearances are frequently found in infants, and these lesions are self-limiting, disappear within a few days to months, and thus require no treatment. And most importantly, parental anxiety should be allayed by reassurance, and regular follow-up should be advised. Let's look at some of the pre-teething conditions which demand oral surgical intervention. In this section, we will deal with some of the lesions of the newborn which require surgical intervention. And just to show you some of the conditions, in this slide we have on our left the melanotic neuroectodermal tumor, on the right is the rare tumor of infancy, and in the middle is the ranula or mucocele. Unfortunately, at this time, I will not be going into the detail of the surgical procedures. Let's look at some more conditions requiring surgical intervention. First one being the varicose vulgaris on the top left hand side, and then followed by squamous papilloma. Then the inclusion cysts, namely the Epstein pearls, Bond's nodules, and dental lamina cysts have already been covered in the previous slides. And the irritation fibroma, then there is congenital ebolus of the newborn, and occasionally localized juvenile spongiotic gingival hyperplasia and pyogenic granuloma. A quick look at the different oral lesions in neonates. The list is too long, right? But to keep it simple, the lesions are just categorized into cysts, Infections, lesions due to trauma, autoimmune lesions, and tumors, which again are either benign, malignant, or teratomas. Then comes the salivary gland neoplasms, so on and so forth. The management aspect of individual entity in itself is very vast and varied. Based on the category they fall under, as in conservative, functional, radicular approaches. This is a picture of a newborn baby born with a cystic lesion in the floor of the mouth. After extensive investigations and histopathological assessment, it was found to be a sublingual lymphangioma mimicking a ranula. And the lymphangiomas are rare lymphatic malformations that are located most commonly in the posterior triangle of the neck, and they affect the submandibular space more than the floor of the mouth. It is present most commonly between birth and 2 years of age, and they have a peculiar characteristic that they do not tend to spontaneous regression. Many require more than one surgical intervention to achieve complete resolution, and the rate of recurrence is up to 40%. If associated with natal and neonatal teeth, the offending teeth may be smoothened or extracted depending on the extension of the lesion, and this entity can further result in displacement of the deciduous tooth buds, leading to eruption anomalies. Let's now look at teething in babies born with orofacial clefts. Cleft lip and cleft palate are fusion disorders affecting the midfacial skeleton. Clefting can occur in isolation or as a feature in a range of syndromes, and the patients with both cleft lip and palate will also have an alveolar cleft with associated labial and palatal oroantral fistulae that may permit oronasal regurgitation. Clefts can affect more than just the lip and the roof of the child's mouth, and it can also impact the positioning, size, shape, and number of the teeth. And consistent exposure to the air can dry up the saliva and allow bacteria to flourish. Patients in children born with cleft deformities often have multiple dental anomalies and may have supernumerary or impacted teeth that require removal or exposure, or missing teeth that require management with either replacement or orthodontic space closure. The maxilla is often narrow with transfer discrepancy, and expansion may be required before the alveolar bone grafting. When it comes to teething, there is no evidence that it is more painful in children with clefts. While clefts can have a significant effect on the way a child's teeth develop, from missing teeth or extra teeth to irregularly positioned teeth, the teething process in itself isn't very different. Natal teeth and cleft infants. This malformation causes injury to the face in many different manners, depending on its occurrence, resulting in morphological and functional incapacity to variable extents. However, as the alveolar ridges is not always affected in all cleft types, it might be assumed that the different types of cleft may not exert the same influence on tooth eruption in these patients. Most natal teeth among clefts are located in the lateral margin of the premaxillary and maxillary segments, unlike in non-cleft neonates, where the lower primary central incisors are affected in over 85% of the time. This suggests anatomic alveolar disturbance with more superficial location of the teeth in the region of the cleft. The strong predilection for the lower central incisors among non-cleft neonates is consistent with the normal order of eruption of the primary deciduous teeth. There was a study which was done by Kadam and Hukeri et al., in which they studied the natal and neonatal teeth among the cleft lip and cleft palate. And they found that the natal and neonatal teeth are far more common in bilateral cleft lip and palate babies compared to the unilateral variant. And the most common place for a natal tooth is on the upper jaw near the cleft side. Surgical intervention for aberrant frenal attachments. I shall not be going into the Kotlos classification of frenal attachments, as Dr. Ghousia has repeatedly been posting it in the group. The role of frenal attachments in oral function increasingly has become a topic of interest among a variety of healthcare professionals. Ankylosing and restrictive maxillary frenum has been implicated in difficulties that are associated with breastfeeding, incorrect speech articulation, gingival recession, and aberrant skeletal growth. Studies have shown differences in treatment recommendations among pediatricians, otolaryngologists, lactation consultants, speech pathologists, and surgeons. Clear indications and timing of surgical treatment remain controversial due to the lack of consensus regarding accepted anatomical and diagnostic criteria for degree of restriction and its relative impact on growth, development, feeding, or oral motor function. When indicated, frenuloplasty or frenotomy or frenectomy may be a successful approach to alleviate the pain. Each of these procedures involve surgical incision, establishing hemostasis, and wound management. Dressing placement or the use of antibiotics is usually not necessary, and the recommendations include maintaining a soft diet, a regular oral hygiene, and analgesics as needed. The use of electrocautery or lasers for phlebotomy and frenectomies has demonstrated a shorter operative working time, a better ability to control bleeding, reduce intra and post-operative pain and discomfort with fewer post-operative complications such as swelling and infection, and also increased patient acceptance. In this slide, I will be focusing on the implications of surgical intervention and teething infants or children. The main reason for surgical intervention is to restore adequate and normal feeding pattern, removal of irritants, restoration of function, and in severe cases to maintain patency of airway. Although excision is the treatment of choice for majority of the oral lesions, the surgical interventions do have some influence on the oral tissues. In cases of superficial lesions like epilis, papilloma, and fibroma, the underlying tooth buds, we try to let it remain undisturbed so that eruption can happen normally. Whereas in extensive lesions involving part of or whole of the jaws, as in cleft and tumors, there may be an injury or loss of tooth buds leading to varied dental anomalies, for instance, enamel opacity and enamel hypoplasia. It may also lead to dilatations of crown from endotracheal intubation, distortions of dental arches, increase in height of the palate, delay in eruption of the primary dentition, and delay in growth of the permanent dentition. The patient and the pediatric dentist should be well informed about such consequences so as to address the sequelae appropriately post-surgery, and also documentation of the pre and post-surgical radiographs becomes a much needed adjunct in formulating a comprehensive treatment approach. Now, the follow-up question is, what after surgery? The child needs to be promptly referred to infant feeding expert or a lactation consultant, and if need be, to a speech pathologist, and also a language consultant, and or a now occupational therapist as well, to improve the cognitive development of the child.
So immediately post-surgery, the child is, it's our duty as pediatric dentists to make sure that there are no hot spots, so the sensory hot spots, which often lead to the gag reflex or the bite reflex in the children. Because a child with congenital epulis or whatever surgical conditions, which Dr. Nyer has mentioned in the previous slides, post-surgery, the child is into gastric tubic feeding, and there is no regular oromotor function of suck, swallow, breathe. So initiation of such things is very mandatory. So help a trained pediatric dentist with the sensory information or a pediatric occupational therapist will come in hand and to restore the oromotor function and enable the teething procedure as well. So otherwise, there are hotspots, sensory hotspots, which often in grown-up children we see as gag reflex or bite reflex, because the desensitization of the sensory hotspots were not addressed. And myself and Dr. Nyer, being the sensory informed oral health practitioners, I think emphasizing this becomes mandatory. And another picture which depicts that, how important the oral zone is for the sensory integration of the whole body is because the oral cavity in itself is rich in nerve endings. And the three important sensory issues, that is the sensory sensations, that is the tactility, proprioception being in the gingiva, gums, tongue, the gustatory functions, and the vestibular. Vestibular is basically the balancing. Now the child is actually the first, the first toy or the first game the child plays is with the gravity, the connection of the child during the, so that is stabilized during the, through the oromotor innervations itself. So this is very important. And one such activity which can be dealt or be mentioned by us is the washcloth teething knots, wherein children is safely biting onto the tooth. Now these washcloths can be kept in the refrigerator, not in the freezer, so that the child cannot get the freezer burns. I'm sorry, I'm running ahead of time. I'll take another 10 minutes before winding up. So this is very important step before the teething happens. Now why before the teething happens? Because once the teeth comes, like I told you, that the teeth becomes the toy or the weapon of the children, and the parents or the pediatricians or the pediatric dentist cannot intervene or do any occupational therapy, or the sensitization cannot implement because of the gag and the bite reflex, which is strong. So therefore, pre-teething, restoring these oral sensory needs post-surgery is a mandatory step and a very important step which is overlooked. And also it is the fact that the whole of the body regulation of the sensory integration is completely focused on the oral zone. This is the first zone wherein the first oromotor sensory coordination happens, as in the suck, swallow, breathe, which unfortunately is missed by the children or the infants who are congenitally born with these tumor lesions and succumb to general anesthesia for a considerable period of time. Now, moving on to further emphasizing that pre-teething stimulation of gum pads is very important, because otherwise this leads to another condition, which is oral aversion, which becomes difficult in feeding, as well as the teething and picky eating. Also, as dentists, we find it difficult for the oral hygiene measures or the toothbrushing battle. So that is when pre-teething stimulation of the gum pads should be implemented. If the pediatric dentist is not well accustomed to the Wilbarger's or the Beckman's oromotor stimulation, then timely, promptly referral of the kid or the infant, the parent has to be educated and be promptly referred to the pediatric occupational therapist, who is particularly working on the oromotor zone, so as to restore the oromotor function of the child as the teeth erupt into the oral cavity. Now, further on, there's a published article on the hygiene of the gum pad, wherein the xylitol, which is a 5-carbon alcohol, non-sugar, it is a sugar-free natural alcohol sugar, which is safe, which was also being studied, and this is coming as spifies or the spiffies, wherein the wipes of the infants can be and periodic, dosage of at least 8 grams 2 to 3 times a day with the wiping can enable the child's microoroflora establishment and decrease counts of the S mutants as well as the lactobacillus, which would otherwise lead us to dental caries. Now, as long as the teeth are not into the mouth, the parents are apprehensive about the teeth coming in or the morphology, the discoloration. Once the teeth are out, and if we are not educating our parents, as dental professionals, if we are not emphasizing on the preventive measures, then the same teeth become a cause of concern because of the multiple decay or complete early childhood caries. And again, parents are, wondering if the teeth were actually necessary for this child, because they ultimately land up with root stumps and swellings. So it's becoming mandatory for us to educate these children on the oral hygiene practices. Now, these are the infant brushes, which are having micro bristles, which are very soft, and simultaneously they're restoring the sensation. The protocols have to be followed. The extraoral sensation has to be restored, followed by the intraoral, not crossing the midline, and cold water. Cold water emphasis is because of the decreased vasoconstriction. Now, we know the gum pads or the tooth follicles are increased in prostaglandins, as well as the inflammatory substance like interleukin-1 and beta, which leads to the inflammation. So cold substance or the cold water or the cold wipes helps the vasoconstriction, decreases the pressure, causes the relief for the child, and decreases the prostaglandin. Then coming on to the actual teething signs. Now, when the teething happens, like I told you all, forgetting about the systemic conditions, it's only the local conditions which are caused for the teething episode. That is, the drooling as well as the inflammation. So otherwise, the
sorry to interrupt you, Dr. Ghousia. Sorry to interrupt you. Just reminding the time. Just running short of time. Just time reminder. Okay. Jazakallah khair.
10 more minutes. So we are focusing only on the drooling as well as the inflammation, the Latin sobriquet, which otherwise tells the dentition difficilis. So there's another myth which deals another, pre-eruption or teething remedy, that is the silver spoon. Now, there is scientific evidence because silver is antibacterial, and again these silver spoons are considered as the treasured heirloom or the generations carry it, and this is again, very important for very reserved for the upper class people who could afford, and that is because of the antibacterial properties of the silver, as well as if these silver spoons are cold enough, then they help in the vasculature or decreased inflammation. So this is a quote by Mark Twain. He says that Adam and Eve escaped teething, so that is a wonderful thing. Moving on to some of the historical teething remedies. Of course, these remedies should not be implemented. One which is missed here is about the use of aspirin, which can cause Reye's syndrome apart from honey, which will be covered in the subsequent slides as we move on. And of course, coming on to the silver, which leads to the mercury use can lead to infantile acrodynia. Infantile acrodynia, actually the excessive toxicity leads to the redness of the hands and feet, and also the destruction of the dental follicles, hypoplasia of the alveolar bone. So infantile acrodynia, that's why the teething powders containing the mercury, which were used in the historical times, should be negated. Some people do use it today. This is the milk of paradise, wherein the cocktail of the opium as well as the cocaine was mixed and dabbed to the mother's nipple, which most often is seen even today. Even today in the cold countries as well as the cold parts of the India, wherein the mother's nipple is dabbed with these cocktail of milk of paradise, and the child is put to sleep because the child gets cranky during the teething period. Of course, this is a lethal lullaby. And of course, whiskey is another practice wherein the child is made to rub the gums with the whiskey. This should not be practiced again. And as dental practitioners, we should be aware of such practices and educate the parents on the same. Coming on to the honey. Now, honey has the Clostridium botulinum, which can cause the hypotonia of the muscles, because the Clostridium toxin released from the honey, which has the spores, can act on the acetylcholine receptor junction of the neuromuscular junction, and thereby causes the hypotonia of the muscles, anti-gravity of the muscles of the limbs, in particular the spinal cord, and leading to floppy infant syndrome. So any child below 1 year cannot be given honey. Just to mention that anybody above 1 year can be given, and how the toxins escape is because the maturity of the digestive system is so much that the toxins can be eradicated or excreted from the body, unlike the child below the 1 year of age. Just before moving to the next slide, mentioning a custom in some of the particular communities, that is the honey practice. Here, most of the countries do practice honey wiping on the palate, which should not be done. The original practice was rubbing of the dates. In subsequent replacement of the dates, in absence of dates, you can always use the sweet fruits like raisins, pomegranates. And another important fact I want to make sure here is rubbing off the sugar content or natural sugars of fruits helps in the prevention of the neonatal hypoglycemia, of course, but the replacement for dates or the fruits should not be honey. And the rubbing also helps in enhancing the circulation of the palate and restoration of the oromotor function as well. Then there is methoglobinemia because of the usage of the benzocaine. Now, benzocaine by FDA was not banned till the year 2018, which was unfortunately lowering the oxygen levels of the blood and rendering to methemoglobinemia. Most of the dental fraternity still uses benzocaine gels or mucopain gels for the ulcers or teething pain, which should not be, because excess ingestion can lead to toxicity. Also, it can lead to the numbing of the throat, palate, and choking, aspiration, because the child will not know how much of saliva or how much of the gel has been ingested, and that leads to the numbness and thereby leading to the paralysis and choking or aspiration of the child. And another thing is the belladonna toxicity, which is most commonly found in the homeopathic tablets. Now, this is a nightshade plant extract, which can lead to neural disturbances, night blurring, or vision blurring. So, of course, this should also be warned against.
When parents see the baby suffering, they just want a solution. Teething necklaces and beads have become an increasingly popular alternative treatment to ease teething pain. But are they effective and safe? The answer is a big no. Teething necklaces, watch out for faulty claims. The teething necklaces can be made of different objects such as amber, wood, plastic, or even silicone. The most common amongst these is the amber one, which is natural substance created when tree resin becomes fossilized. Amber contains succinic acid, which is thought to have anti-inflammatory and pain-killing properties. It is believed that when the beads are worn next to the skin, succinic acid is released into the body, providing relief from the pain and tenderness of teething. In theory, this is a great idea, but in reality, in 2019, a study by Canadian and Australian researchers published in the medical journal titled Complementary Medicine and Therapies reported that the succinic acid found in Baltic amber is not released when worn next to skin, and that succinic acid is not an anti-inflammatory. There's not enough evidence that these necklaces work. A word of caution is the Food and Drug Administration released an official warning in December 2018 after receiving reports of children choking on beads that break off and an 18-month-old being strangled to death by an amber necklace during a nap. So parents, be careful. As babies begin teething, parents look for products that can help soothe the child and provide pain relief, such as teething tablets, gels, sprays, ointments, solutions, and lozenges. Benzocaine or belladonna form the active constituents of such gels, solutions, and lozenges to relieve inflammation and pain. The consequences of belladonna and benzocaine have already been dealt with in the previous slides, and the FDA issued a warning to consumers about the homeopathic teething tablets containing belladonna belladonna, which pose an unnecessary risk to infants and children, and urge the consumers not to use these products and dispose of any in their possession. The pharmacies were advised to take products in contention off the shelves. In the year 2017, December, the US Food and Drug Administration announced they will begin to crack down on the dangerous homeopathic medicine industry, after which a local law firm filed its first lawsuit against the manufacturer of these teething tablets and gels, which led to the death of many infants. A word of caution, again, beware of what you buy and what is marketed by the pharma companies.
Moving on to the non-pharmacological remedies. So cuddle therapy, which is actually causes the increased release of the oxytocin, reattachment assurance happens, there is emotional regulation. Then ice cubes, as I always emphasize, that decreases the vasoconstriction of the gums. Then rubbing of the gums, that is the pre-teething stimulation, which I mentioned on the sensory stimulation. Teething rings, food for chewing, of course, the edible foods for chewing. Now in the food, again, it is very important that, it should not have choking hazards. Of course, strict vigilance or monitoring by the parent should be done, not let the child alone, even if the edible food is being encountered by the child. The natural foods examples being, the teething cucumber, and then you have the mesh teethers, because that should not help in choking, and the peanut biscuits. The peanut allergy and egg allergy are very common in children, but also there's a debate that introduction of these peanuts or eggs in the early age increases the oral tolerance, thereby reducing the allergies in these infants. Now, moving on to one complication of the natural food, which was left to the child unvigilant or non-vigilant by the parent.
In continuation of the natural or food remedies for teething blues, this is a very interesting article we found from otolaryngology case reports, which we would like to share. The chicken, they say, holds an important place in the cultural heritage of Samoa, a Polynesian nation of the Pacific Islands. This is reflected in the name of the country, with Sa meaning sacred and Moa meaning chicken. The chicken is at the center of a number of local practices there, including the chewing on chicken bones as a traditional remedy for teething infants. As a consequence of which, 2 infants landed up with airway obstruction caused by aspiration of the chicken bone. The radiological investigations were inconclusive due to the cartilaginous component of the foreign body. Therefore, tracheostomy was done for both the infants to intubate and the foreign body extracted under general anesthesia. So again, a word of caution, don't leave your teething child unattended after giving something or anything to chew on. That's it from me. Back to you, Dr. Ghousia. Over and out.
So finally coming to the teething signs, which are the 2 major concerns, is basically the drooling, and then there is a frostbite or the freezer burns. Now, drooling is basically because of the excessive saliva. Now, excessive saliva is because of the immature salivary glands and also immature oromotor functioning. The child is still unable to swallow, not learning to swallow yet. So there is excessive saliva which is overflowing. The child is not able to swallow inside. So there is excessive dribbling of the saliva, which can lead to dribble rashes or drool rashes, which is exclusively to the circumoral region or maximum to the neck and chin. But this should be ruled out from the eczema, erythema toxicum, hand, foot and mouth disease, which also involves the extremities as well as the mouth sores, but unlike the dribble or drool rash. And so this can be combated by giving the backings or the plastic backings and the wipings regularly. Another complication is the frostbite or the freezer burns, which is otherwise popsicle paniculitis, because we often these children tend to go pick something which is cold because of the vasoconstrictions. So these 2 concerns are the ones which has to be addressed. And also just before finishing the presentation, I would like to say diarrhea is very common in these children because of the excessive saliva which the child drools as well as swallow, and there's an increased content of interleukin-1 and beta, which leads to the stooling, the stool being diluted, leading to the diarrhea in these children. So the safest ways are, of course, the teething, hand teethers, which are well fitting. The word of caution here, Consumer Act Protection initiated 1998, wherein these products should be free of bisphenol, BPA and phthalates, as well as it should include the food grade silicones or hardwood material, which are edible, safe, non-toxic, carcinogenic, because the child tends to ingest these materials into the body. So it's very important for the parents to check, or the dentists as well, while prescribing, to check if it is non-carcinogenic products before advising this or before picking it for the children. So teething pacifiers, which has the mesh, which again prevents the choking hazards, is very important. Teething mittens actually makes sounds which can actually initiate or help the sensory stimulation regulation of the child as well. So this is just before conclusion. Since we started with the myths, folklore, wisdom, why not end with the same, which is very associated with the teething. Now the teeth is about to shed. So of course our tooth fairy comes in, which is a favorite legend for the dentists, for the parents, for the child as well. Now the story behind this, rooting back to France, I quickly finish it, that the France literature states that the tooth fairy becomes a mouse below the pillow of an evil king by for protecting the queen, which is soft-hearted. By knocking off the teeth, the mouse kills the evil king. Now this storytelling is very important for the child's psychological development. The fairy tales are very important. Yes, I'm ending. The fairy tales are very important for the child's psychological development and also enhancing the oral health behaviors. Now that is why the fairy tales, and especially as a pediatric dentist, it becomes very important for behavioral guidance of the child. Now that is a France character. We can also see the books as well as the cartoons which are available there. And yeah, of course, reminding ourselves nationally that today is Children's Day, that is the first Prime Minister's birthday, and internationally it is celebrated on November 20th, which is 6 days from today. And again, I remind that taking this opportunity to eradicate or dispel the medical myths. So we become the activists for doing the same, as well as I urge my fellow fraternity to become sensory informed pediatric dentists or dental clinicians, wherein the child is seen as a whole for holistic well-being, as well as the multidisciplinary approach. Please do not hesitate or shy away from seeking the multidisciplinary approach for the well-being of the child in question, because the parents are entitling their whole world onto a dental chair. So it becomes of utmost importance to see everything around the mouth as well, looking at the child as a whole. Now, just before conclusion, I thank everybody who sat through the whole presentation, who bared with me even the technical glitches. I missed 15 minutes in the beginning. So I thank all. And of course, it's not one giant leap, but many small steps which helps us to, cover the journey ahead. And of course, the first step is always the hardest step. And I end this by telling that eat well and teeth well, especially for the children. And of course, if there are any doubts, I think Dr. Nyer also can take up. And for the uninitiated people, this is Khalil Gibran, one of the favorite poet, who sums up, the child's philosophy or the triology in the three phases of life that keep me away from the greatness which does not bow before children. So any doubts, I'm not sure if Dr. Nyer is available in his busy schedule of working. I would take up the question answers, otherwise can be posted in the group. We are always there in the GDP group.
Right. Jazakallah, Dr. Ghousia, and Jazakallah, Dr. Nyer Firdoose, for your beautiful, beautiful presentation. It's been an eye-opener for many things to me and to all the people who are hearing on you on this group, even online, which is it is live telecasted on to the YouTube also. So basically, you pediatric dentists and pediatricians, you make every child, special and unique, and make the childhood memorable by ensuring them a better life and giving them better smiles. And thanks to the entire fraternity, dental fraternity, attending today for this beautiful webinar. Taking the questions for today, I think most of the questions which have been posted is already, mashallah, answered in every slide of yours. Just to read out those questions. The first question is by Dr. Arshia Khaled. She asks, how safe are teethers like teething necklaces or frozen teethers?
Yeah, of course. I think Dr. Nyer mentioned about the ample teething necklaces, choking hazards, which are banned by the FDA, and the regulation is implemented as well.
Exactly. Just to add on, so most of the parents, what they generally do is, I think teethers in India, they are available over the counter in every medical shops, and even in the normal grocery shops, even in those gift centers, what I have seen. So these teethers, which have, it should be BPA free and phthalate free, because these are the two chemicals which can induce serious medical conditions when, the toddlers start using this. You have to, get in touch with your pediatric dentist or your pediatrician and get recommended by these fellow doctors, which is the right apt teething device for the child.
So just to add on, I think I have seen a lot of teething necklaces. I think they colloquially call it as talisman moti. I don't know if you've come across this. But when I was small, and then I've heard my grandparents and then my relatives suggest, the talismani moti. I think it is a teething necklace, which has been worn. I think it's made of lead or some heavy metal, which is just hung around the neck. This poses a severe choking hazard for any infant. I mean, they are loosely tied to the neck, and then this children, they have a habit of just pulling it out from their in their hands and then putting it in their mouth and then keep chewing on it. So this poses a very serious choking hazard. I think the parents should be very aware of this, potential hazard of choking, and then they have to take care as to not avoid this teething necklaces. As I've already spoken in the teething necklace slide, that not everything what's shown or professed has to be true. They generally don't work.
Actually, these teething necklaces, what you added, Dr. Nyer, what I have seen, see, basically, I'm a clinician and I keep seeing these young children with those necklaces around, not the entire beads, what I've seen, a single small pearl. I did ask them what is the reason. And there are two reasons what most of the parents give us or give me. One is to protect the child from the evil eye, first thing, and to stop the diarrhea during the teething phase, which most of the children have. So they assume that putting that bead around the neck would stop the diarrhea. So this is one common myth which they happen to carry, and I do tell them it doesn't make, and you have to remove, but ultimately it doesn't work. Dr.
We
Ghousia,
tried our best. We tried our best to bust all the myths today, inshallah.
Yes, alhamdulillah, alhamdulillah, alhamdulillah. Okay, the next question again is from Dr. Arshia. She asks about ectodermal dysplasia, where the teeth are tapered or pointy, and it's a big concern during feeding. How can we help in such cases? Very nice question, actually. Dr. Ghousia?
Yeah, smoothing the edges of the pointed teeth, and also checking with the mother if the feed is possible. And then thin lining of the restorations, restorative material onto the coney surface should help, actually. Because these milk teeth are not sensitive like our permanent teeth. So a little bit of, rubbing or, de-sharpening these edges should help the feed.
And you also get stoma-adhesive favors, intraoral stoma-adhesive favors, which do cover the sharp edges and then blunt them out.
Can you enlighten more on this, Dr. Nyer? Can you enlighten more on this?
It is something similar to wafers which are used for ostomy. I don't know if people are aware of a procedure called ostomy. There are certain stoma-adhesive wafers. What they are stuck on the skin or over the rings. But in cases of ectodermal dysplasia and natal and neonatal teeth, where they're just really sharp, they are commercially available certain rings called stoma-adhesive rings and wafers. What they do is, the basic idea is they just stick it over the tooth, sharp edges. It just blunts them out. It's like a thin film. You're just laminating the tooth. Additionally, nice. you can also put a thin layer of composite, like Dr. Ghousia have just mentioned now.
Yeah, great. Yeah, makes sense. Again, mashallah, dynamic Dr. Arshia. Again, the third question she asks, whether the child or the infant should visit dentist only when there are problems related to teeth, or is it a myth or a fact? And what is the ideal age for the child's first dental visit?
According to American Academy of Pediatric Dentistry, the first visit is at the 6th month. And that is the whole idea why simply teething is presented today, because there's increased number of queries with the AAPD and AAP suggesting the parents to visit the dentist at just before the first birthday or the first appearance of the tooth, that's around 6 months. And also anticipatory guidance, which happens for the parents to be, the couples are faced and spoken on the teething habits. So, anticipatory guidance again is the curriculum in the pediatric dentistry, wherein the parents to be are educated on the probable concerns related to teething just before the child is born as well. So the teething, the issues of the guidance or anticipations are starting much before the child is even born. So That is the whole idea of dental home concept, actually. That's more into detail of pediatric dentistry, the preventive measures, the dental home concept, wherein the couples are, the parents to be couples are seeked and given the anticipatory guidance, and virtually then, the follow-up visits happen. So it's as early as the gestational period, to be particular.
True, madam. Very true. I think, counseling the parents is far important, because the dental health would, hamper the mental health of the child in the coming time if the dental health is not addressed properly. Very true. The next question is by Dr. Asam. He asked, does eruption cyst associated with rotation of tooth also? Is the criteria for the rotation tooth, not the criteria, sorry, is a rotation of tooth also cause eruption cyst?
Of course, the movement of the dental follicle, because the dental follicle, any irritation, as it is, the dental follicle is rich in prostaglandins, iconosides, interleukins. So, of course, any irritation or disturbance in the suck-swallow suite, suck-swallow breathing or suckling, there's mouthing in the child, because of the urge of the sensation. The child tends to urge and irregularly, mouth or stim the particular non-edible stuff. So, of course, the dislodgement of the tooth happens, and eruption cyst is more particular because enhancement of inflammation is there, of course, yes.
Yeah. Next is by Dr. Saida. She asks, what is the time duration of the teething of a tooth? Will it last for a week? Question mark. How many days can we expect these symptoms?
Yes, I think I mentioned, or probably I missed it, but it's 8 days in particular, and the 5th day the occlusal cusp appears. So 4 days before the eruption and 4 days after the eruption, the child is uneasy because of the post-inflammatory or pre-inflammatory reactions. So 8 days in particular is what is literature saying, and 0.7 mm of the tooth is erupted per month. So that is especially for the primary teeth, and permanent teeth, of course, it's 1 to 2 mm, it ranges differently. Yeah, I think I mentioned it.
So, yeah, so probably, Dr. Ghousia, just to, this is my query to you. If you happen to, put the child on a teether, so how long should we hold the child with the teether? Is it for a few months till all the teeth erupt, till the half teeth erupt? Till when are we going to?
As long as the child is satiated, sensory stimulation, sensory urge has to be addressed. It's very important for the overall child regulation. So this is something like body massaging. You're asking, parent, how long the child can be massaged. Now, the external body is massaged, but then we often forget the intraoral, massage or pre-teething stimulation, which I termed it as. Of course, this is not there in the literature. This is something which I've been working on. I think, of course, Dr. Nyer is also there in it. The sensory smart oral healthcare deals with the pre-teething stimulation in particular, which is very rare and not found in literature. But of course, it has to be given as long as the child is enjoying it. And the child, of course, disregards the teether when the satiation happens. So long as, something which we cannot formulate. It's the child's demand.
No, that would be, like a double-edged sword. That would become like a habit, like, like a pacifier or like a milk bottle or something. Eventually, during one stage, when you try to stop that habit, the child might become crispy or, stubborn. So there is some, repercussions to this habit also.
I doubt so, sir, because sensory stimulation and regulation needs to be addressed. So there cannot be vice versa. They cannot become a bad habit. Probably the child is more hyposensitive and needs more, the pedial receptors or the touch receptor, the proprioceptor receptors are so high, and the child is hyposensitive that the urge is more. So you cannot take it as the habit being, addictive.
Right. So for further details, I would suggest the other members to just look up our video, which is already posted in our channel, the Sensory Smart Oral Healthcare. I think there's a very comprehensively we have dealt with the sensory issues in children. And then regarding the hyposensitivity and hypersensitivity, Dr. Ghousia has very beautifully elaborated in that particular presentation. I think I would suggest the members and also their friends to actually go visit our channel and then take a look at the video.
So is teething associated?
Yeah, sorry.
Yeah, please carry on, Dr. Ghousia. I will take the question after you.
Yeah, so probably in case of doubt like yours, sir, that you fear that the child can become addictive or habituated, you can always consult a pediatric occupational therapist. because he or she is in a right position to judge whether the child is satiated, or it is just the teething urge or the sensory activity. Now the oral sensation is something which we are addressing, but the overall, the brain sensory integration is something which we overlook, and we might not be the experts in it. So the concerned occupational therapist as well as the psychiatrist will be in proper position to actually judge and differentiate between the continuation of the habit or not.
I think our next question is from Dr. Basha. He asks, is teething, is it associated with headbanging? So I think these are the children who are rock stars in the coming future rock stars. Start headbanging.
I don't know about the children associated with headbanging, but definitely as dentists, we.
So I think the whole gist of the presentation is dispelling the myths. And, this is again a popping up new myth. So of course, this cannot be teething. Teething has only local problems. Let's break the ice. Teething issues are only dealing with the local issues. Anything beyond needs to be checked. Probably the child needs to be checked otherwise for the systemic, evaluation.
I think during this phase of the growing phase of the child, the only headbangers would be the parents actually. If the tantrums happening with the child, I think the father with the one corner and the mother on the other corner with headbanging.
So the question is,
also the imitation behavior of the child.
No, the question asked was teething is associated with headbanging. We don't know whether headbanging is associated with teething. We don't know.
Dr. Basha, you wanted to add something on that, or can I just proceed? I'll just unmute you. Dr. Asim House. Dr. Asim?
Yes, Nazim can hear me.
Yes, we
can hear you. Thank you, Dr. Ghousia. Thank you, Dr. Nyer Firdoose. Excellent presentation, mashallah.
You're all mentors for us, Basha.
No. We are all learning from you. We are just students. We are back today. So many new things we learned today. Thank you very much. Dr. Nadeem, it's fine. I got my answer. Thank you, ma.
Fine. I think we have taken up most of the questions, and mashallah, most of the questions were already answered in your slides. I think, alhamdulillah. Fine. So I think before I conclude the entire session, thanks a lot, Dr. Ghousia. Thanks a lot, Dr. Nyer Firdoose, for taking your,
thank you so much.
Thank
you for giving us such a
time during your practice,
opportunity.
During your prime practice hours, taking out, sitting in the clinic and, giving and answering the questions. Dr. Ghousia, madam, mashallah, she is an colossal of knowledge, and we are always
extended the time. I apologize all the members who are listening. And
no, we never realized, madam, when the time was running. And as you rightly said, November 14th is Children's Day here, and November 20th somewhere. I don't know. November 20th is celebrated where?
Internationally.
So I take it that November 20th we have Ghousia 2.0 bouncing back with one more webinar on Children's Day. It's really refreshing. Many things we have learned, and many things we have unlearned. Actually, that is one good thing. And me sitting amongst you, galaxy of stars, it's a privilege for me to sit amongst you people. Thanks a lot to give me an opportunity to host and be a moderator for this session. Okay, we'll conclude the session. Any doubts further can be taken on to the GDP platform. Any doubts can be answered by Dr. Ghousia or Dr. Nyer Firdoose. Alhamdulillah. Looking forward to the coming webinars. Jazakallah khair, everyone. Assalamu alaikum wa rahmatullahi wa barakatuh.